Hello again, this is Dr. Jenkins. We are here to go over the next chapter, which is on disordered eating. We've come close to the end of the semester, so really well done, but you can't quite let off of the gas pedal yet. So to round out the lecture, we have two shorter lectures. One of them is on disordered eating, and the other one is on immune function and exercise. And these are two topics that are pretty unique to sports nutrition. If you're talking about, I suppose disordered eating would be appropriate in any nutrition class, but when we bring athletics into it, it brings in a whole nother little avenue. So these are important chapters, a little bit shorter, but still important. Okay, so let's just jump right in. You'll notice that this chapter is called Disordered Eating instead of Eating Disorders. That's kind of the way that people tend to talk about this now. It takes a little bit of the stigma away, but more importantly, it is more inclusive. What I mean is if someone has a certain eating pattern, it doesn't have to necessarily meet what the DSM or what the medical professionals have said. It has to meet A, B, C, and D. This is more inclusive. It's important that we're able to recognize, even if it's not a quote-unquote eating disorder as it's described in a textbook, a pattern can still be disordered eating that needs to be addressed. So here's our outline. We will just get right into it, shall we? Okay, so as I've already said, it's important that let's see, what color? How about a new color this time? This is probably the most fun I have. Although if I was seeing you in person, that would be even more fun. And I apologize for the noise. My neighbors are out doing something. So we've already talked about this definition. Let me use a little bit thicker. There we go. This definition being the way it is, disordered eating. And you can see included in this definition, it's a broad definition that it doesn't necessarily have to meet a specific set of symptoms defined in a textbook. All share something that's a bit pathological and involves someone's unusual focus on their body shape and body weight. And their eating habits tend to follow that unusual focus. Of course, we're familiar with the more traditional eating disorders, quote unquote, anorexia and bulimia, and we'll talk about those, but we'll also talk about some other disordered eating patterns that would still fall into this category. What's included in all of these disordered eating patterns is a sense of dysmorphia. Make sure that you understand this definition. This picture, I think, does a pretty good job. Dysmorphia means that your view of yourself is not necessarily what it actually is. So even though this woman presumably, this woman is shown to be very skinny, right? So if we look at her here, she's very skinny. What she sees in the mirror is not in line with how she actually is. And what goes along with this dysmorphia is a preoccupation. So it may be an imaginary defect, as is the case in this picture. It's imaginary objectively, but it's not imaginary to her. I'm going to have to close this window, and I apologize. If it's getting to me, I imagine it's getting to you, and I apologize. So it could be a preoccupation with something that is not objectively true, but it could also be an obsession with something that it is a minor defect. A woman has bigger hips, whatever the case may be. You can read through the characteristics. As you can see in these definitions, it's trying to be very inclusive. So it can be frequent, it can be occasional. It doesn't have to fit into a definition in a textbook. Notice it affects males and females. We'll talk about the statistics. You may not be surprised to learn that this type of thinking occurs more commonly in females, but that is not to say that it cannot occur in males. It is more prevalent in some sports than others. You can already probably imagine some sports that are weight specific, particularly we think of women and gymnasts or distance runners, but it can occur in a lot of sports. So you don't have to necessarily shoehorn it into one thing. Statistics on something like this are very hard to obtain. This is something that you have to ask people about. You can't just do a test. You can't get their height and weight and figure out BMI. You have to ask them, and they have to be forthcoming. And with anything like this, people are less likely to be forthcoming. So we have estimates, but they're likely underestimates. You can see it's more common in females, so I'd like you to know that. It is tend to be more common in white middle-class females, but we're going to focus for now on the females. Here you can see a nice table from your textbook, and it talks about the, why can't I think of the word? I'm sorry. Talks about the occurrence of disordered eating in certain types of sports. Of course, it is going to be more prone to happening in sports where aesthetics or how you look matter, like gymnasts or figure skaters, and also to a lesser degree, weight-dependent sports like wrestling, like a horse jockey. Even you could think about distance running where being lean is an advantage. I'm not going to ask you any of these numbers. I suppose I would like you to know what types of sports it's most common in, but you don't have to know the exact numbers of these studies. All right, just stop to take a drink there. I apologize. So what are some risk factors? Gender is the biggest risk factor. Females are much more likely to have some sort of disordered eating. In fact, they're about 10 times more likely compared to their male counterparts. I'm not going to ask you that number because the statistics are hard to get, but it does show you how much more prevalent in women. And I think that you can understand why women are looked at differently. I think we can all agree on that. How they look is more important to society. There's certain standards they need to fit into, whereas men tend to be viewed with less of a magnifying lens. Women tend to have a higher body fat percentage to begin with, so even though it's normal for a woman, and I mentioned this in the body fat percentage chapter, it can play with a woman's mind. 20 to 30% is normal for a college-age female. I mean, if I'm a competitive athlete and they tell me I'm 25% fat, that can sound really bad, even though it's, normal. Women have some unique circumstances. So we have a period, which can obviously lead to some water retention during that time and weight gain. Pregnancy, higher body fat percentage, so societal pressures to be thin. And I've given you some examples of sports where women, it's more important to look a certain way. As always, just make sure that you're reviewing what I'm circling or putting in a square. All right, in terms of males, the prevalence is increasing. There's a different set of norms. So men, the ideal is perceived to be a lot of muscle mass. So it's a little bit of a different societal stereotype, but it can be just as psychologically damaging. This is a picture up top here. Oh my God, it's been so many years ago. There used to be that show on MTV. I'm even forgetting the name now. True Stories or Real Life or something. And they followed this dude that was preoccupied with his skinny calves. So he got calf implants. So on the right, you see the calf implants. You must be really worried about how you look to get calf implants. But there's societal pressure. It could really happen to any of us. Other risk factors. Being an athlete does make you more likely. By the way, these are all things that can make you more likely. So certain traits of these make you at more risk for developing some sort of disordered eating. being an athlete means that not only can you limit your food consumption or change your diet, but you can also exercise more. So we'll talk about people who tend to be over-exercisers. But that adds a whole other thing. There's more stress added to performance. If I want to perform on a team, there's more focus on me. I've got to be a certain weight and look a certain way. Certain personality traits, which by the way happen to oftentimes go hand in hand with being an athlete. Think about a type A person. A type A person is very scheduled. They're very disciplined. So as an athlete, a type A person is a good thing. They are disciplined, they get out there, they work hard, they do what they have to do. And it can also mean that they're more disciplined and more likely to be micromanaging how they view themselves. And then if they develop some sort of disordered eating pattern, a type A person is going to be better at sticking to it. So it can actually become a cycle. Certain types of environments, so if you're around other people that meet the quote-unquote stereotype of what you think you should look like, if you're in a environment where you have a coach, and this happens, there's been articles about this, I want to say the Nike project, when Nike sponsored coaches for distance running, for elite distance runners, and there was a distance runner who quit because there was so much pressure on her weight. So she was in an environment where her coach kept beating her over the head, not literally, but pressuring her. You got to lose 2 more pounds. You got to lose 2 more pounds. If you lose 2 more pounds, then you're going to make it to the end. But it was just too much for her. And then certain lifestyles. I think it just depends also on who you're around and the lifestyle that you adopt. But all these things can make you more at risk for developing disordered eating patterns. All right, we're going to cover some clinical eating disorders, which are by the book, and then we're also going to talk about some others that fall into the disordered eating realm. Okay, when I say a clinical eating disorder by the book that I'm talking about, maybe you've heard of it, is the DSM, Diagnostic and Statistical Manual for Mental Disorders. This is the 5th edition of it. This is what psychiatrists will go to. Someone comes in, do they meet the medical standard for anorexia? Well, let me look in the book. And this book will have a list of characteristics and activities, and if they meet it, then they are diagnosed with anorexia. Now we're learning that you don't have to necessarily meet those to qualify for disordered eating, but I'm just telling you what the reference book is. All right, anorexia, you know what that is, right? A preoccupation with thinness. This is a person who is obsessed with being thin. And in their obsession to be thin, they do not eat enough. So they starve themselves. This is much more common in women, but particularly women who are late adolescent and early adulthood. I can tell you, I'm a woman, I can tell you from experience, when puberty kicks in, it's much different for men and women. We know that, but to experience it is something different. Men, which I've never experienced what that is like, to have all of a sudden a huge surge of testosterone, that has its own challenges, but I can speak to what it's like going through puberty as a female. And that means all of a sudden, because of increased release of estrogen, the hormone, you have fat beginning to deposit in places. So I remember very clearly, I was athletic, I ate reasonably well, but all of a sudden, after I reached puberty, I could no longer eat the same thing that I was without gaining weight. And it wasn't an abnormally amount of weight gain, it was just the normal weight gain. My breasts got bigger with more fat in them. I had more fat being laid down in and around my hips, because that's biologically what happens. But it can be really difficult when you're doing the same things and all of a sudden, through no fault of your own, your body is depositing more fat. And that's what it should be doing. But as an athlete, as a person going through a tough time and you're trying to figure out who you are, it can be really hard. I put these in here not to frighten you, but to point out that it can be very, very dangerous. These are individuals who, because it's a psychological disorder, are not capable of seeing how thin they really are. And psychologically, no matter what they look like, they feel like they're too fat. And as it is not surprising, our mind can be a very powerful thing. And even though you can objectively know, the scale says I'm 110 pounds, I objectively know that that's thin, it doesn't matter. Your mind, your emotions don't always bend to the will of objectivity. So it's easy sometimes to be judgmental, but I think if we look within ourselves and really think about maybe we've experienced something different where we objectively know something, but our mind and our emotions tell us something different, and you can't just change it. It's not like you can say, okay, emotions, brain, just change. It doesn't happen like that. All right, what are some of the symptoms of anorexia? I've already mentioned amenorrhea, and amenorrhea is a loss of period. To be clinically diagnosed with this, it has to be a loss of period for a woman for at least 3 months. You can read through some of the other physical symptoms. It's not surprising: weakness, fatigue. They're more susceptible to injury. This would be something that you could look out for in a female athlete. And there's, of course, also a lot of psychological symptoms. Because it is such a psychological disorder, it leads to anxiety, always worrying about staying thin. What am I eating? Am I going to stay thin? Depression, because you're just constantly obsessing about this and you can't help it. Social withdrawal. I don't want to be around other people because I don't want them judging me, or so forth. Long-term effects. It could compromise the immune system. It could lead to poor bone health, osteoporosis, and it can absolutely lead to death. All right. There's another clinical eating disorder called bulimia. The root cause is the same in that there's a preoccupation with a certain body image. It's usually thin. So in most cases, people that are bulimic have the same root cause as people who are anorexic. They have a preoccupation with being thin. They just have a different way of going about it. Someone who's anorexic will starve themselves, eat very little. Someone who is bulimic will binge eat and maybe even purge. And it tends to happen in cycles where they may not eat for a period of time, but then they just binge eat, and then they feel bad for binge eating because of their preoccupation with being thin, and they may throw it up and purge, or they may not. So the purging type are people who purge, the non-purging type are people who don't. So they could fast for a while and then binge, or they could binge and then excessively exercise. These are equally as dangerous. You notice here for the purging type, it doesn't only have to be through self-induced vomiting. These people will take laxatives. They will take diuretics. They will do an enema. It is such a psychological stress to them that they will do whatever it takes. Someone who is bulimic, it's not as easy to identify. Typically, someone who is anorexic, you're more likely to see the symptoms. You know someone, all of a sudden they begin looking thinner and thinner, and they become more obsessed, and they look thinner and thinner. There are many instances where someone with bulimia will appear to be a normal weight, or even maybe a little bit overweight due to the binging, but they still have that obsessive psychological disorder where they obsess about being thin, and they're still disordered in their eating, and they can still have a lot of side effects. The psychological symptoms appear to be very similar as anorexia. You can start to see some of these things, And maybe you know someone or you yourself who has ventured into these territories. At first, it may not be noticeable, but if you look carefully, you can start to see trends. Bulimics tend to disappear right after eating because they want to go purge. They become more secretive, more agitated. Physical symptoms, this can be sometimes worse. They could have a lot of GI issues from the purging. You can think about if you're throwing up, all the acid from the stomach, the hydrochloric acid, comes up through the esophagus and the mouth. And the esophagus and the mouth are not built to handle the acidity. So it can lead to burning, gum problems. They're more likely to have weight fluctuations depending on their binging behavior. Okay. All right, and this should say 5, and I apologize for that. So now let's move on to the eating disorders that are not clinically in the DSM, but they still qualify as a disordered eating pattern. Not as well studied, they still occur and can, of course, be problematic. There's something that has been termed anorexia athletica. So it's, as the name suggests, athletes that develop some anorexic behavior. They may not meet the actual signs and symptoms of someone who is anorexic by the book, but they have some tendencies towards anorexia. They are restricting their caloric intake severely. And as I mentioned before, an athlete, not only can they restrict calories in, they can also do it on the other end. They can excessively exercise and burn more calories as a way to lose more weight. This can tend to be more cyclical, as an athlete has an in-season and an out-of-season, and it would occur more towards the competitive season. The goal behind this is thinness, but it's also related to improving performance. Exercise addiction is another term we've coined, as it suggests, individuals who exercise excessively. This can be difficult because if you're talking about high-level athletes, exercising a lot isn't a bad thing, right? Oh, it means that they're going to be in better shape. They're going to be better at their sport. But you have to think about the psychological aspect and other abnormal behaviors. So I mentioned the psychological aspect. As an athlete, if you're an athlete or you know athletes, missing a workout, that sucks. You know, I judge myself. Sometimes life happens. Sometimes I just can't get my butt out the door. And every once in a while, you know what? That's okay. I'm not training for the Olympics. And even if I was missing one workout every so often, it's okay. But we can judge ourselves, right? But in this case, it would be psychological symptoms that take it the next step. I have known people who do this, and maybe I've even bordered on this, where it interferes with my everyday life. I'm no longer seeing my friends as much because I got to exercise. It's affecting daily things. So I think you know what I'm saying. And this can occur with other things. So a lot of times there's exercise addiction with severely restricting your caloric intake. And that would go back to anorexia athletica. So they can go together, or it could just be this. Muscle dysmorphia. This is an example of something that is likely to be more common in males. This would be, instead of having an obsession with thinness, this would be when someone has a severe obsession with muscle size. And the word dysmorphia up top tells us that it gets to a psychological point where no matter what they objectively see in the mirror, they don't see that for what it is, and it becomes a psychological obsession. It's never going to be big enough. This could also use with other types of addictive behaviors, steroid use, etc. If you want to go down a little rabbit hole, you can do some research on Greg Valentino. I believe he was suffering from some muscle dysmorphia to get biceps that big. He was obviously juicing, no doubt about it. In addition to being arrested, he was known for his biceps exploding. So you can look at that if you want to read. I think there's even a video. You can see his biceps exploding. They got so big. All right. Another disordered eating pattern is binge eating disorder. This is when someone has a pattern of binging, but it is not associated with other behaviors like fasting, excessive exercise, or purging. And, I just want to be clear. We all have different diet patterns. I mean, I know on a rainy day, if I'm just kind of feeling a little down or blue, I might do a little binge. It's happened in the past that I eat a whole bag of chips, and I'm not proud of it. But we could identify that as someone that just has a blip here or there. When it becomes more regular, then we would categorize it as disordered eating. So you can see they give a timeline. I'm not going to ask you this, but it would have to be occurring regularly to be considered disordered eating. All right, I mentioned this before, but this is perhaps the best time to talk about it, and that is the female athlete triad. It's not that I only care about females, even though I'm a female. But it's an interrelated series of conditions that absolutely happens in some women. And it is just due to both biological things, the fact that women tend to have a higher body fat, that women have a period. And it also introduces some psychological pressures that are more put onto women than men. The idea that a woman has to fit into a certain look. And especially in an athlete, all of those psychological and biological factors can result in these three conditions. And it doesn't have to be that, this always happens first, and this always happens second, and this always happens third. No. They happen in any old order. But the truth, here's the thing, they are all related to each other. If, let's just say an example, if a female starts to have disordered eating, because she's not bringing in as many calories, she's more likely to lose her period. And if she loses her period over time, she's more likely to have poor bone health. And by the way, disordered eating, not bringing in enough nutrients, can also lead to poor bone health. So these all interrelate. One leads to another, one affects another. This is specific to women, right? Women have a biological predisposition to osteoporosis anyway, right? Women tend to have weaker bones than men just because we're smaller in stature. Women, because of their hormone profile, tend to have weaker bones. Women obviously have the risk of amenorrhea if they don't eat enough and exercise too much. That's pretty unique to a woman who is menstruating. So just make sure that you know the three components. It's of course more common in sports where weight is emphasized. I've mentioned in previous lectures, I've experienced amenorrhea as a triathlete, exercising 20 hours a week, training for the Ironman. You train so hard, you're watching what you eat, because being skinny in a triathlon is an advantage. Less weight to carry when I swim, bike, and run. So if I can experience that, many, many other people have. Over time, it can be really bad. So it's important that we are aware of it and can hopefully pick up on these things and try and do something about it before it gets to be too bad. All right, so what are the effects of all of these disordered eating patterns on performance? I've included pictures of 2 female athletes who have publicly spoken about disordered eating, Nancy Kerrigan and Zina Garrison. I'm aging myself a little, but that's okay. All right, if you have disordered eating, no matter what it is, if you're not eating enough, or if you're binging and then throwing it up, or you're binging and then fasting, it's going to result in low energy. It is precisely what an athlete doesn't need. An athlete needs more energy, it needs more calories. If it is taken far, you will lose muscle tissue. Ideally, if there's a preoccupation with thinness as an athlete, anybody really, but ideally you want to lose fat. But if this continues and it becomes pathological, you will not only lose fat, but you will lose muscle. And that will impede your performance. If we don't have as much vitamin mineral intake, it can affect a whole sort of things. Less calcium, we can affect our bones. And you have increased risk of injury. This is oftentimes, my background is as an athletic trainer, and I saw it a lot. I would start to see the same people get injured. And there were certain injuries, stress fractures, tendinitis, that were representative of overuse or of a low caloric intake. Okay, so I'm going to end this chapter talking about some things that may help in how to manage if you or someone has any disordered eating pattern. Of course, I want to clarify, I'm not a psychiatrist. I'm not even a psychologist. But I've dealt with it as an athletic trainer. I've had other female teammates come to me in confidence and say, hey, Christine, I'm worried about so-and-so on my team. She's not eating enough. And it's very challenging to deal with. You're glad that person came forward, but this is something, because it's so psychologically based, you have to handle carefully. So I'm going to share some things that I've picked up from my research and from reading and also my personal experience, but with the caveat that I'm not a trained professional. Okay, this could be you. It could be you that's dealing with these issues, or just like me, someone may come to you. I know, our friend so-and-so, or this athlete so-and-so, and it puts you in a position, oh my God, am I going to say anything to them? Am I not going to say anything? What's the right thing to do? I care about them, but I don't want to be judgmental or, attack them, and they're going to feel like I'm judging them and they're going to get worse. So it's really hard. These things are probably common sense, but it's worth thinking about. Number one, I would say, is to listen. Listen about people's concerns. Listen, even if you suspect someone has some kind of disordered eating, just listen to them. You could just check in. Obviously, you're not going to walk over and say, I've heard you've been starving yourself. What's going on? Well, that would not be a good tactic, now would it? Listen, just check in. Hey, how's it going? How's your day? How's your boyfriend? How's training going? Listen, okay? Don't give advice first thing. Listen. Sometimes the best thing is that person fesses up to you or to someone. Because in order to do that, they've got to face it themselves. So in some ways, that's more important than anything you have to say. Just listen. You can give some ideas later, maybe, but just listen. It's a difficult question about, do you tell other people, or if someone comes to you in confidence, do you approach them? Maybe sometimes yes, sometimes no. You have to think about the situation. but you certainly don't want to out them to other people unnecessarily. You want to gain trust, and you want to monitor for behavior. And you can do that. You don't have to just do that by, hey, so-and-so's not eating. Have you noticed it too? No, you would just gain their trust, just talk. Hey, have you noticed, so-and-so? Man, she's really been kicking ass on the field. How's she doing? Just, those sorts of things. But it can be very hard because we have a tendency to want to help. We want to fix things. And this is not something that can be fixed like other things can be. Certainly refer to a professional if needed. Even if they ask you not to, you may find eventually it's what's needed. I can't tell you when that line is crossed, but I think sometimes it is. Be careful with interventions. They can go really sour. Just because you've watched the TV show Intervention doesn't mean that you're an interventionist. So think long and hard before you do anything like that. Talk to a lot of people. Consider the age. If it's someone under 18, you may have a legal responsibility to talk to their parents. That can also be really tough. So each situation is unique. I would obviously go to them first if it was me, but just think about all these things. On the same token, once the rubber meets the road, you want to be upfront with them. I think a lot of us can appreciate that. After the niceties, when push comes to shove, just put it out there. Hey, it's come to my attention that you aren't eating as much as you used to, and I'm worried about you. Okay. This can be very hard, no matter if you're going to be a phys ed teacher, if you're a coach, if you're part of some kind of athletics and someone comes to you. It can be really, really hard. All right, in terms of the clinical management, I think this might be almost the last slide. Okay. In terms of clinical management, again, I am not a professional. From what I've read, the best approach is multidisciplinary, where you might want to get a healthcare provider, like a physical, a primary care doctor, but also a mental health care provider. You want to ultimately get to the root of why it's there. If you treat the symptoms, you're never going to get to the root psychological issue. And of course, you want to be appropriate and realistic with your goals. Here are some specific techniques. You don't have to know these. It's just what I've read about. All right, so thanks for listening. Kind of a tough chapter to talk about, but absolutely necessary in our world. All right, see you for the next chapter.